My name is Elizabeth Cross-Mickle, and I'd like to invite you to join us for our Seattle Angel Meetup. We're pleased to have Chris Axman, who's going to be talking about what product does the healthcare industry sell, and we've got some good discussion points going on for that. I will repost the articles that are in the chat box in a few minutes so that new people who are joining can capture that since it doesn't stay. Then my name's Elizabeth Cross-Mickle, and I am substituting for John Seacrest today, who is actually at an ESG session. And it's important that I'm here actually because I am the co-chair of APIS Health Angels with Bob Thong. I'm going to let Bob introduce himself in a minute. And so we're delighted to be launching our initiative for health sector investment and health sector companies to be prepared for investment. So happy to have you all on board with us. And Bob, perhaps you could introduce yourself next.
Yes, absolutely. Hi, everybody. Some familiar faces from prior workshops, which I'm pleased with. Yes, my name is Bob Thong, practicing physician. Been doing angel investing with John and the SAC team for the past 5 years. Realize that there's a gap in angel groups focusing on health tech. And of course, with an uptick in all the health tech startups, we formulated APIS Health Angels to focus on that, which one of the main goals is to get more healthcare folks into the angel space, given that they are lack of knowledge that it even exists. And my third hat is doing a startup where we're leveraging technology to bring kiosks into outpatient clinics to increase the efficiencies of check-ins. So pleasure to meet everybody again.
Chris, I'm going to save your introduction a little bit more until we get closer to you. And so, Alicia, would you introduce yourself?
Sure, thank you for having me. My name is Alicia Adamson. I have a background in building massively multi-stakeholder, multinational health information technology services. And I have worked in public health, community health. I worked in translational science as the Chief of Health Informatics Integration at the University of Texas Health Science Center at San Antonio. Mouthful. I've done a lot of really cool things, and I stepped away from healthcare about 8 years ago, and now I'm stepping cautiously back towards it, and noticing that some of the outcomes are worse, and I'm feeling discouraged. But healthcare transformation, it's my thing. So I'm looking forward to hearing about what y'all been up to the last 10 years. So.
We're so glad to have you back.
I'm glad to be here. Thank you.
Alicia, you're perhaps referencing the fact that life expectancy in the United States went down last year.
I actually am, it's more about translational science for me. When I went back and looked at, when we talk about from bench to bedside, bedside to curbside. And when I left the industry, I think it was like 12 years was the bench to curbside. And then last I looked, it went up to 16. And I was really discouraged by that. So that's the one that gets me. But yes, I saw that our life expectancy is decreasing.
Gwen, could I ask you to introduce yourself?
Absolutely. Glenn Prestwich. I'm here. I'm an organic chemist by training and a serial entrepreneur helping other faculty start companies. Done 20 some odd companies with other faculty over the past 30 years. First in New York, then in Salt Lake City, and now here in Spokane, where I run the SP3 Northwest incubator, life science incubator. One of my companies is called MXDX Bio. We're making organoids on a chip for improving drug discovery and drug evaluation processes preclinically. And I'm a consultant with a big company in France called HTL Biotech, which is the premier manufacturer for hyaluronic acid, and a lot of my work has been in hyaluronic acid space. So happy to work with entrepreneurs that are doing small and large molecule chemistry, and that's the kind of advice I can have people I can advise. I don't know anything about health tech.
That's good expertise to bring to us. And Gwen, would you like to introduce yourself? I know you were having some mic difficulties. Okay, how about I move on to another G, Greg?
Hi, I'm an angel investor for roughly the past 5 years, including a few times through SAC. My wife is now going through SAC this cycle as well. So I'm excited about that. My overlap in interests with health is through my day job at Amazon, where I got to be the lead engineer of Alexa's HIPAA eligibility. So became an expert in HIPAA, and now am fully focused on privacy in general. So.
Great, thank you. Jack, would you like to introduce yourself?
Yeah, you got the video going there. I'm Jack. I guess I'm a healthcare venture capital investor, so doing so on behalf of a healthcare system in Washington State. So we are doing strategic investments, and so spending a lot of time connecting entrepreneurs to system experts within the health system, understanding use cases, understanding ease of implementation, getting a lot of feedback. So spending a lot of time in that activity, as well as seeking out opportunities that are core to our health system strategy from a venture timeline. So that's what we're doing.
Thanks. Dale?
Afternoon, everyone. I am Dale Willard, Business Development Manager at Life Science Washington. I'm a former entrepreneur and involved with the angel community in Seattle. And what else? And I mentor companies, small companies, through the Life Science Washington Institute and CoMotion, University of Washington's CoMotion. Thanks.
Thank you. Shoal?
Good afternoon, everyone. I'm Shawal. I'm a first-time investor in SAC20, so I'm looking forward to that. I'm here to learn about the healthcare space. I'm not very knowledgeable about it, so I'm just going to listen in on the conversation and ask questions if I'm confused. So hopefully you'll have some good answers for me. And thank you, and great to meet you all.
Nice to have you here. Ken?
Let me unmute. Good afternoon, everyone. Ken Allgood, founder and CEO of HealthFlow. We are a patient-centric healthcare coordination capability. We call ourselves a bit of a Internet of Things for the patient. We are based out of Alexandria, and we have a development center in Tacoma. And sorry about being late. We're preparing for HIMSS. So we'll be in the interoperability showcase there along with Red Hat, one of our partners. So please come see us if you're going to be at HIMSS.
And it's nice to have it in person this year.
Yes, it is. And it seems like the numbers are going to be sort of close. At least that's what they're claiming based upon the last email I got.
Good.
So we'll see.
Thank you. Sarah?
Oh, hi, I'm Sarah Gallo. I'm a PA in telemedicine in Colorado, and working with a startup that is focusing on innovative solutions for the safety net community to close gaps for accessibility to services for specifically the safety net.
Thanks, Sarah. Margie?
Well, good afternoon. My name is Margie Benching. I am the founder and CEO of Golden Sherpa. I participated in SAC this past February. Hi, Glenn out of Spokane. We love to see other Spokane supporters of entrepreneurship. I have been seeing all the meetups, and so I apologize for this being my first, but so Golden Sherpa is Senior Living Marketplace. We connect senior communities who have availability with people who are looking for availability in real time. And we're doing that here in Spokane, Washington State right now, but we're going to go across the country. So we're pretty excited to be here and be part of the conversation today. Thank you.
Thanks, Margie. Nice to see you here. Nisa?
Hello, good morning, guys. I'm sitting in because I have been going to the Entrepreneurs Coffee Hour. I am a veterinarian who is working to launch some beta groups on having batched care for wellness and preventative health for veterinary patients. So a little different than some of your other fields, but I thought this would be a timely, relevant topic for me. So that's why I'm joining today. Thank you.
And Nessa, connect with me afterwards. I have a friend who's a vet who's doing some interesting things.
Awesome.
Sudhakar?
Oh, hi.
Hi.
Yeah, sorry. Yeah, I'm calling in from Boston. I have been on the Cambria Grow Slack, and I thought this is an interesting topic for me to be able to really understand. We are doing something on mental health. Are you able to hear me?
Yes, thank you.
Oh, okay. So your frame froze up for me because probably my end. But yeah, I'm very curious. That the topic is very provocative, to say the least. And I'm working on a startup that is an AI ML based platform for mental health for Gen Z.
Thank you. We've seen one of our previous companies was on mental health. So glad to have you join us, and that you're a perfect introduction to a provocative topic from our speaker. Chris, that sounds like it's a good segue to you.
Well, hello, everybody. My name is Chris Saxman, and I've been involved with this community, I don't know, for a couple months now, and I really have been enjoying it, along with Cambria Grove. I have been, I'm a 3-time entrepreneur, and before that, ran an angel investment group that became New York Angels. I think you're talking to my old boss next week, David Rose. I'm going to tune in for that one for sure. But yeah, when I was doing that, I kind of decided the folks on the other side of the table were having all the fun. So I've now done 3 of these things. And the most recent one was Cirrus MD, a telemedicine company. Decided to wear the t-shirt. We grew from when I joined it was just me and 2 co-founders to probably the number 5 in the market now after the 4 big guys. We serve about 10 million covered lives. I left there in August because I sort of done what I came to do and have been active in mentoring and other digital health companies through Techstars, the United Healthcare Techstars program. I'm on the board of a digital health company here in Denver. Sarah and I know each other from Roundup Market. So good to see you, Sarah. Have been increasingly focused on trying to figure out, well, okay, what's the broader context here? We all have know that healthcare is broken. We all, have specific points of view based on what we've done, but I had the chance to sort of step back a little bit. And so that's what I really want to talk about today as I go forward, and hopefully we'll be able to do a little something in my next gig that will nudge the ship just a little bit that way. So with that, maybe Elizabeth, I'll just jump in. What I will say is actually there's 2 topics I came to prepared to talk about. The one that was advertised, and then also Elizabeth and I had talked about that because I ran an angel group and because I've done a couple other startups, I've got a point of view on fundraising. So a very tactical, very different view that maybe some of the entrepreneurs and maybe some of the angels might appreciate. And so we spent a few minutes at the end on that if people want. But with that, I don't have any slides, but I'm going to sort of walk you through some of my thinking. And then I want to have a discussion because, I don't claim to have the right answers. I have a point of view, but it's a really big topic. And I know the biggest thing I've learned in 8 years in healthcare is I don't know very much about healthcare yet. And, I'm always learning things, and I'm sure I can learn a lot from all of you and vice versa, hopefully. So with that, let me launch in. So first of all, I'm going to ask a question, and if you read my essay, don't answer because you'll know the answer. But for those of you who may not have, if you could just put the answer to this question in the chat here, and we'll see where we go. And that the question is, what product does the healthcare industry sell? You just, if you like, you didn't read the article, just take a second and dump it in there. I'll be interested to see what people come up with. Let's see. Okay, I've got wellness. Anybody else? Well, security. Okay, that's good. Longevity, treatment of disease, health service. Okay. Risk management, insurance against painful health outcomes, comfort. Yeah, those are all good answers. Natalie, not NASA, I hope I'm pronouncing that correctly, or NISA.
NISA, sorry.
NISA.
NISA, I like horses neigh. It's a really tough one.
There you go. Yeah, I mean, the answer is health. And what I'm saying is that's why we go to the industry. We don't go for we're not going for the experience of going to the doctor. There's no such thing as recreational surgery. I mean, there might be cosmetic surgery, and that's maybe not for purposes of health, but no one goes to the cosmetic surgeon because they like the experience of getting surgery. Like you go to Disney World because you like the experience of going to Disney World, right? You go there because you want to be healthy. And why do you want to be healthy? You want to be healthy so that your body doesn't get in the way of your needs or your wants, what you need to do during your life or what you want to do. And, if you think about any product and you think about what it is the vendor is selling, well, you got to look at what it is what are people buying? And you and I go to the doctor because we want to be healthy. So health, that's the answer. So wellness, I think, is relatively close. And what's interesting is when I ask this question to people in the industry, you got all kinds of diverse answers. When I ask people that aren't in the industry, they all get it right away. And I think that's somewhat telling. Okay. So if people are purchasing health when they go there, does the industry sell health? Well, no, it doesn't. Why is the industry not selling the product that people want to buy? Well, to me, there's the fundamental problem we have in healthcare, in my mind, in this country, that underlies all the symptoms that we all talk about and we all hear about in the press, is that there's a real mismatch. There's a fundamental mismatch in the economic structure of the industry. So the industry, as we in this call all know, is structured like a B2B industry. And we buy healthcare the same way we buy aircraft carriers, don't we? Big payer over here, the Defense Department. I don't know who builds aircraft carriers over here. And they spend 3 years locked in a conference room someplace with their lawyers and their engineers, and the contract pops out, and a decade after that, out comes an aircraft carrier, and that's how we buy. That's how we buy healthcare in this country. I mean, I know I've negotiated a few of those agreements, and even the little baby ones I negotiated were, it took a year sometimes. But healthcare is not a B2B industry. It's the ultimate B2C industry, isn't it? If you have $1 left, you're going to spend it on your health or your kids, right? It's the ultimate B2B or B2C industry. But like I said, we don't have doctors or other providers selling health to individuals because that's what they want to buy. We have provider organizations selling encounters to health insurers. And that's the way the industry works. Furthermore, individuals don't think of buying health. That's not how they conceive of the industry because they've been trained to think of it differently. Their parents, their grandparents, maybe even their great-grandparents, going all the way back to World War II, if not beyond, have been thought to consume, to approach this industry differently. So they don't think of buying health. What do they buy? Well, what do they know they buy? Well, they pay for premiums for health insurance. So they buy health insurance. I mean, even if their employer's paying for it, they still, know there's a deduction. And they purchase copays and they purchase co-insurance, right? That's what they pay. That's what they buy. I like to speak in analogies, and this is a little bit like going to Las Vegas, buying a room at the MGM, say, okay, that's like your entrance ticket. That's like buying health insurance. That's your premium. And then going down to the floor to the blackjack table, putting your ante down on the table, and then walking away and letting somebody else play your hands with your money, right? And you go while you're at the bar, they're playing your hand, and you're going to hope that they're going to do a good job and you're going to come back good, but you don't really know, and you have no control over what actually happens with that blackjack hand, right? And I think as I was sitting and taking some notes on this, I realized, that creates a profound sense of helplessness. And I think a lot of people, especially when they're dealing with more substantive health issues than just having to go for your annual physical, they really do feel helpless. They don't know, they have no information, they have no way to make real decisions. They just have to trust people, and they know that these people don't always make the best decisions. I'm not talking about the medical decision necessarily, although sometimes that's part of it, but the whole system. And that sense of helplessness, again, I think is one of the symptoms of what I see as the underlying issue with our medical system as it works today. Okay, well, if that's the case, right, what might the industry look like? Let's assume that we could start from scratch. I mean, there was no such thing as a healthcare industry, just like say there was no such thing as a streaming TV industry a couple of years ago, right? And we were going to start from scratch. What would it or might it look like? This thought exercise, and to be clear, all this up until we talk a little later is all sort of thought exercise territory. Well, before I dive into that, my thoughts on that, one thing to keep in mind that if what it is where people want to buy is health, and that's what we're going to sell in the ideal world, we have to. Sometimes they're really healthy, sometimes they're not. It alternates, right? And obviously you want to be as high up in that function as possible for as long as possible. And this isn't my idea. The CEO of Bind has a really elegant podcast that maybe later on I'll dump that link in as well, where he sort of makes that point. But your health is a continuous function that you care about. And the interesting thing about that is, in this idealized world where we're starting from scratch, well, that means that if you're selling health, you can sell products to people at any time in life, not just when they're sick, not just when they're injured, or when they're coming in for their annual physical, because again, health is a continuous function, and there are things, and you always want to be healthy because you always want to be able to do what you want to do in life. So sellers could specialize either horizontally or vertically. You can think of a vertical integration play where you might have everything from your PCP up through surgery, or you might have specialists that sell things that aren't just for when that specialist when that person's body requires specialty medical care. For instance, and I just totally made these up. I mean, I'm not suggesting these are necessarily good ideas, but for the sake of example, how about a sports medicine practice attached to a gym, or to a personal training facility? How about an FQHC? And this one actually I think is a relatively good idea. How about an FQHC that provides fresh vegetables and other good healthy food in food deserts, where they may be the only facility that could possibly do that in that community, either because it's in a rural community or because it's a trusted place in an urban, in an underserved neighborhood and urban environment. And so what they're doing again is providing the value that people want, but reinventing when it is that people in our industry could become involved. Okay, so that's, like I said, that's thought exercise territory. We all know that the real question we have to ask is, what can we do? Given the current state of our industry. There's, as we all know, there's massive inertia driven by incumbents that have significant financial interest in status quo. We know that, if any of those do want to move, there's a real prisoner's dilemma there to be a first mover. And we know that, there are very rigid state and federal regulations that are really hard to bend and that are into change, even for Congress, frankly. And those are just three barriers I threw up. I picked out, we could think of probably 50 more here in short order. So there's a lot of constraints. So obviously we can't just throw out the industry and start over again, but what can we do? Well, again, let me take a step back and tell you about this guy named Mark Geen, who's a CEO of a company here in Denver. Not in the digital health world, but he's just I think a really brilliant people CEO, team building CEO. And he, those corporate values that every company seems to have, and most of them are really feel good type of values. Well, his are very focused on how to operate the business. Like one of them is iterate to success. So, for his business, using lean startup principles and lean design principles is really, really important. So that's literally one of his corporate values. And his idea is like, look, I want everybody in the company to use those 6 corporate values every day, because they're going to be, like it's 9:30 on a Tuesday morning and I got to make a decision between this and that. And they're both could be very valid. It's not clear which way should I go. Well, look to the values. If you can't decide, it's not obvious what the decision is, look to the corporate values. Is this one, I'm just going to decide on my own, or is this one, or in this way, let me go run an experiment and see, and then iterate on that experiment while you do this. And I think the same applies here in healthcare, in the sense that there are many plausible outcomes or many plausible decisions we as entrepreneurs or investors can make in any one given day. And if it's Tuesday at 9:35 in the morning and we ought to make a decision, and one of them is going to sort of nudge us a little bit towards consumerism and the other is going to nudge us more back towards, reinforcing the current B2B structure, we'll do this one. If they're both feasible, if they're both feasible within the context of the business. And I think that last point is really important because, you can't have a situation like somebody else pointed out, like a design principle being delight the customer, right? Well, that's not a design principle because the opposite is just not tenable, to disgust the customer. Well, no, you're not going to do that. So it has to be two things where, either one of them could be good for the company. I'm going to do this one over here because it's going to begin moving us in the right direction. And, obviously I'm not talking that we're, if we all follow this approach, we're not going to change the healthcare system overnight, or probably in the, in the next couple of years, but maybe in the next decade or so, that we'll be able to begin having an effect. And if nothing else, we'll understand what it is we're shooting for and why, if our goal is to reform the healthcare world and not simply just, make money from it or integrate or introduce new technologies. So where's a good start? So, and again, this is food for thought for all of us, including myself. But one way you can sort of begin changing that mentality with you and your colleagues is many people, and including at Cirrus, will say that, we're in a B2B2C industry, meaning that, we work with, at Cirrus, we worked with large health plans and employers, and they were our customers. But then we would provide a service to the members or the employees of our customer, B2B2C. So just flip it. Language is normative. The way you talk about things and the way you think about things matters. So no, let's not call ourselves a B2B2C industry. Let's call ourselves a B2C2B industry. So we have customers, and they're the people that are going to use they're the individuals, they're the patients, if you will. That's the customer. And then we have payers. Just like, in the traditional world, Doctors have payers. Well, now we've got payers. And that might be an employer, a self-funded employer. It might be, a health plan. It might be a health system. And so think of ourselves that way. I mean, except for the companies that are, pure B2C, where, there are some of those too. And that's great. So anyway, now I'm sure a lot of you are thinking, well, yeah, that's all well and good, Chris, but like healthcare is different. It's really complicated. It's really complicated. How are we going to possibly do this? And you'd be very right. I'm the first one who can tell you that the devil is absolutely in the details in this industry. Having built Cirrus from, like I said, almost nothing to, where it is now. Yeah, the devil is really in the details. And I think there's a couple places where we can focus. And I've listed just ones I came up with. I'd be really interested in if there's other areas that you all can think of, and once we transition here to discussion. So the first is sort of what I mentioned the last time, or just previously, which is try to change the mentality of your organization to be obsessed with it, to be customer obsessed, like Apple is customer obsessed. That, hey, my customer is the patient, is the person purchasing health. Again, that's the B to B to C being more of to B to C to B. And, like I said, one of my mentors always says language is normative, it matters. And that's why, I'm not, in saying that, I'm not saying we're going to change any contracts or anything. It's still going to be, but it's just a mentality shift. How do we think about what we do at 9:35 on a Tuesday? Do that. And then I would say another part of that would be to educate your organization on probably the entire organization on what human-centered design is, because I think getting the right product is a key thing for creating a consumer product. Well, the good news is there are a lot of people in this country that are really good at the product process. Not a lot of them in healthcare, though. And again, this is human-centered product design, not, can we build, like Alicia, you're saying, you want to talk about bench to, things. Well, that's a whole different side of the ballgame. That's almost a different industry in my mind, and incredibly important, but that's not what I'm talking about today. Because there, the client is clearly, remains a B2B industry, I think, and should be. But for, the sub segment of the industry that's, directly or semi-directly related to providing services to the public, think about the public as your customer. And then use that human-centered design principles, borrow them from other industries where we're really good at it, this type of thing, and apply them here. Think about what the whole product is. So the product, it shouldn't just be, well, this is the software we're creating. It's serious, in my mind, the product, there was always four integral legs to the product. One was the tech, or the software platform, which was really good. The second was the business model, because we designed business models that allowed care to be unlimited and free to the patient. So that, for what we were doing, was a key part of the product, because it provided unfettered access. We wanted to get all barriers to care away from the patient. And part of that we did through the actual product design, because we were able to get doctors. Well, good example of that. We always talk about, you can get to see a doctor in under a minute, and that's like literally true. And we did that in part because there's a clinical component to how we staff. There's a product, like a technology component to it, but there's also a business model component to it. Because again, it's free. So you don't have to go through the barrier of inputting a credit card or worrying about any of that. You just log in and the doctor's right there to talk to you. And you don't have to talk to a nurse practitioner or nurse as an interim step. You might end up talking to an NP, but you'll talk to that person right away, and that person will take care of you, will solve your issue. And then the final part of the product at Cirrus was member engagement. It's all well and good if we create this great product, but if no one knows about it, then it's not of use to anybody. If no one trusts it, it's not of use to anybody. So the whole product, and that's that, you know, I give that as an example. And of course, every business will have a different set of things, but think about product expansively the way we do in other industries. So that's the first thing, mentality and product design. Second, I think that we need to get right, or that is to give, if we're talking about, I should have mentioned this earlier, but the real issue with the mismatch in economic structure is that the buyers and sellers, the buyers are the patients, the sellers are the actual doctors or providers. Neither one of them has any agency in the economic transaction that's going on. They're not sitting in that conference room for 3 years. It's, you know, their bosses, and then, like it's the HCA people and their lawyers and the United Healthcare people and their lawyers that are in there. The people actually buying and selling or producing and consuming aren't in that room. They've put their ante down and walked away from the table. And I guess you could say that the doctors, it's like the dealers there, they've walked away from the table in a certain sense too, at least in an economic sense. So if we're going to fix that and give agency back to these people, we have to do it in an appropriate way. And that's going to depend on where that person is in their continuum of health. And we're going to have to give people the right tools to actually use that agency. You can't just make people make decisions, but without any intelligent way to make such decisions. So I think some of those things, and I'm sure we can think of far more, but I think you'll all recognize these. The first is we have to have access. Everybody involved in the transaction, primarily the patient, but also the doctor, has to have access to all pertinent information, to data. So that's data transportability. And then you need to have transparency. So the patient and the doctor, and doctors need it as much as patients do. Doctors need to know how they're doing relative to maybe what else is going on, and they don't necessarily have that right now. And patients clearly need transparency. Pricing transparency is one that gets a lot of press, but you can think of others as well. And then I think the most important thing is you can give people all the data in the world you want, but if they don't have the ability to use that data, it's useless. So we need to give them decision support tools. Now, again, the good news there is that other industries have created very sophisticated decision support tools to make really complicated industries really, really simple. I mean, financial services being a primary example, right? It used to be that, that was very opaque. When I started on Wall Street back in the 90s, there was opacity. You didn't know what was going on. The markets were not efficient. Now they are, because we have decision support tools. And
well, Chris, on our audience here, we've got people who are developing decision support tools. Ken, I see you shaking your head. Sarah, you've been doing this in terms of your telemedicine, and Margie, you've been trying to get people focused on decision support in order to how to care for your elders. So I think that innovation is not just in finance. It also, we've got some folks around the table here, and so maybe we could, you tell us when, Chris, you want people to start jumping in on your.
Well, I've got a few more points to make, and then
Okay.
I really do want to get everybody's feedback, as much for my own sake as for yours. Yeah, no, and you're right. There are a lot of, I guess my point I was trying to make is that through digital technology, digital transformation, we are able to give people the tools that they will need to exercise agency. And I think that is something that there's always a lot of pushback. Healthcare is different. It's too complicated. I don't think that's true. I really don't think that's true. Now, it's going to be different, for people that are suffering from brain cancer than those that are suffering from, say, a hernia, or who need to go pick a PCP. Of course, it's going to be different. But that doesn't mean you can't change your mentality about how to approach these things. And I think that's the point. So there's two more, I think, focus areas I wanted to mention. The third one is payment structures. So I'm sure a lot of you will immediately think of value-based care, and rightfully so, because clearly one of the issues is that if we're going to do something where people have, you give people agency over and create a supply and demand issue, then you need to have the right incentives to induce people and enable buyers and sellers to transact intelligently and to do the right thing, not the wrong thing. Right now, people are incentivized to do the wrong thing, as I'm sure we all know. One way to think about this is, can you envision a value-based arrangement, care arrangement between one patient and one doctor? Well, it turns out that's pretty easy. I mean, at the simplest level, it's just a credit card, but we could think of many other arrangements too. And I think there's a lot of innovation that could happen there. And then the next thing is risk mitigation. So obviously, it's all well and good to say that you're going to pull your credit card out to go to the get your annual physical, or have somebody look at your cough. It's another to pull your credit card out again when you have brain cancer. So we need to have risk mitigation tools so that no one is left behind, so no one is bankrupt because of healthcare costs. And I think we have to have the right risk mitigation for different portions of that curve, right? When you're healthy, your demand for healthcare is very elastic. When you're really unhealthy, it's very, very inelastic. So we can't consider healthcare to be, one good. The elasticity varies greatly depending on where you are on that function. But right now, health insurance treats it all the same, because you buy health insurance for everything that could possibly go wrong with you. It's almost like, I love analogy, I'm going to use a Wall Street one. It's almost like you have a collateralized bond obligation, and I don't know, which is basically a synthetic security where you can put other securities that have different risk profiles. Well, let's assume you have one that has loans in it, and you have in there a treasury bill, you've got some corporate bonds, which are sort of risky. You might have some defaulted Venezuelan debt from the 1980s that's in there. You might have, Vinny the loan shark's loans in there, and the loan that your Uncle Joe gave you, all stuffed in there, right? And now you're going to go ask traders on Wall Street to trade, price it accurately and trade it. Well, they can't tell. Those are not, that makes no sense. And to a certain extent, that's what, the healthcare, when you buy your healthcare, your health insurance premium, you're covering off in the risk that you might get toenail fungus and the risk you're going to get brain cancer. So how do we break those risks up and price them appropriately? Now that one I certainly don't have the answer for, but I do know that's a real problem. And again, that the Bind podcast I'll drop in there was is one that sort of turned me on to that idea. So all of that sounds great, and it's all pretty institutional. The last thing, and to me, is almost the biggest challenge in all of this, if we're going to make any of this work, is understanding how to market to individuals to convince them that they should be buying health, not walking into the casino and anteing up and then walking back out. Like I said, people have been trained to think about the industry in that way. Their parents, for 50, 70, 80 years. And we're going to have to teach them that there's a better, turn that perception around so that they begin thinking of this as a positive thing they want to consume, not a negative thing that they have to consume. How can we take something that's potentially, again, they can create a sense of helplessness or frustration or anger and fear because you have to consume it, especially when you're really sick. And again, you're at that inelastic part of the demand curve, and turn it into something you're eager to consume, that you're delighted by. I don't know the answer. Again, I know that the good news is we're really good in this country at marketing things to people that they didn't know they needed, and then convincing them they can't live it without it, no pun intended. Again, I use this as my case study. And I think the ultimate thing in this is we have to rebuild trust. People have to trust and value their partners in the health industry if they're going to think about consuming it and doing so happily. And with that, that's kind of what I mean, it's a lot, but I'd really be interested in everybody's thoughts. I'm going to get my notebook out.
So I know we've got thoughts. Sarah, maybe you want to talk a little bit. You've got a safety net population a bit. Would you want to jump? Can I ask you to start, or anybody who would like to comment on what Chris had to say?
That's Alicia Adamson. I have 100,000 little things I want to say, and I say every single one of these points, Chris, I could sit down with you. We could spend weeks talking about these points. They're so juicy and so sad. But a couple of the things that kept coming out for me as you were talking, one point I do want to make is that, and maybe this is because my experience is largely coming out of underserved populations, but there are people, and we don't call it recreational healthcare seeking, but there are people who go to the ER because that's the best human connection they can get.
Yeah, I agree with that, but they're not going, I totally agree with that. We saw that on Cirrus too.
Yeah.
But they're not going there for the experience of being in the ER. They're
No.
going there because they're lonely. Perhaps, probably they have behavioral health issues. So they have, you're absolutely right about that, 100%. But again, they're not going there because, woohoo, I can either go down and see a movie or I can go hang out at the ER. Let's go to hang out at the ER today. That's not why they're going there. That's a social determinant of health issue. It's very sad. We had somebody on Cirrus who every week developed some new really serious medical issue. And finally, we connected her with social services because that's what she needed.
Yeah. There was a project that I really was excited about 100 years ago, and I was talking with Tom about it, and I called it Beautiful Health. And it was really about changing the language of healthcare.
Okay.
As you were talking about, what is that big marketing campaign? And I start thinking, Guy Kawasaki, right? How do you enchant? How can you create an enchanting product? And I have felt for a long time that we need to change the way we talk about health and disease. I think it's something that, wow, we got to do it in little bits and pieces, maybe.
Yeah.
When I go to I wish I had some very specific examples, but even just words like disease, to go into a doctor and have them say, well, you have disease in your sinus. For someone who is not very health literate, that sounds earth shattering. What do you mean I have disease in my sinus? What do I have to do? And it causes panic. And we have like this cortisol industry, right? Healthcare is terrifying.
Helplessness. Yeah.
And so we can address that. How are we going to get buy-in? How are we going to convince people that, I think having healthcare it sounds like a good idea, right? And then we associate healthcare in the media and all of these places. Healthcare is associated with fragility and lack of capacity. Healthcare isn't shown as a beautiful thing. Health isn't demonstrated as something that a community owns, that this is something that we do as a society to hold each other up and build each other up. And then we have opportunities like in community health centers and FQHCs. I loved your idea of taking nutrition to that place, as I have a lot of experience in rural communities, underserved communities.
Yeah, that one, like I said,
vegetables, right?
Yeah, I'd be interested in Sarah's take on that, because I know she works with, Sarah's still here. She has worked with some of the FQs here in Colorado, and as has Prime. So yeah, and that one, and you know what? You know who's actually doing that for real is Walmart and their health centers, because they're like, okay, you can walk over and you got all the vegetables you need right next door after your checkup. And those are not in rural areas, but they're in poor neighborhoods in cities, for instance.
That's lovely.
Yeah. And they're trying to, ideally the idea would be, well, okay, we know what you buy. We have that data. We know what your, A1C levels are. Let's talk about this.
Yeah. And on that note, one of the projects that we're supporting with NAC, the North American Community Health Centers, is specifically to use our platform to incorporate SDOH details. We're part of the Gravity group as well, which, yay, some standards have been improved for SDOH. So actually adding more details to what's available and from a standards perspective now. So incorporating that into the community center flows so that they have more insight into the general environment that they're about to send a patient back into, specifically food desert, transportation issues, that sort of stuff. So yeah, those are certainly some of the areas that we've got work happening. It's just sort of starting. I guess the question I would have for you, from a patient perspective, one of the big challenges, and even the work that we do with DoD and VA, where there's kind of a perceived inherent trust in the machine that you're being taken care of by, is that trust factor. And your thoughts on really how to build that trust from a more proactive engagement on behalf of the patient, on the part of the patient rather, that this solution, this system, this collection of things is really going to support them. So it's not simply I go to the doc when I'm broken, much like our relationship with a car mechanic. When the light goes off on the dashboard, I take it in. It's very similar. When I have a major pain that won't go away, okay, fine, I'll go to the doctor. We need to build beyond that relationship. And so, I mean, what are your thoughts on that?
Great question. I think, let me give a high level thought and then maybe, an example. I'll go back to the example we were just talking about. So at a high level, I think that, again, we have to change everybody's, like, if we're going to implement what I'm talking about, we have to change everybody's mentality. Okay. And I purposely started by talking about the product and, this human-centered design. Well, that's a corporate thing. And that includes clinic. I mean, that's a business related concept, right? And so the doctors have to think of that they're selling health, not selling encounters to some, evil empire, affiliated health system, right? Or health plan, excuse me. What if they were actually like, hey, I've got a patient and I want to make that, my job is to support that person's health, to make them delighted with being healthy. Okay. And that's how I got paid. That was my point about a value-based contract that's not designed by a bunch of data scientists and lawyers, right? But rather is, one person and another person getting together, or maybe it's a group of people. You can think of a care team, right? Or the staff of your FQHC, and they're the 1,000 people in the community that they serve, getting to know them and like, hey, I'm not going to get paid unless these people over here really like me. And I realize that if you're in a small town and there's only one FQHC, that doesn't quite work. But go with me for a second. Okay. Point is, if that's your mentality, that I have to actually, the customer's all right, and they're my customer. The customer's not this. It's not Medicaid. It's not United Healthcare, like I talked about earlier. But it's this person, and I got to go and then I'm going to go out of my way to make that person like me. And if you like me, you're probably going to trust me. And if I'm selling health, not health care or sick care, as people talk about, then I can sell you things every day of the week. Every year. I don't have to wait until you're sick to engage with you. Okay. So going back to our grocery store inside of an FQHC thing, or a farmer's market, say every Wednesday, there's a farmer's market in the parking lot of the local FQHC, and you get good fresh vegetables there, right? Well, how about, there is that. And instead of the farmers, it's the doctors out there selling these things to you. So you can trust them because you you engage with them and you get to know them when you're not sick. And you know, that's just, you know, I was just making, I just kind of came to me as like a somewhat exaggerated example, but you get the point. If you're going to be able to sell health, and that means you can sell to people all year long, every year, something. And I, you know, again, I'm not claiming to know what that is, or even if that's possible, but you get the point. Well, then you're a trusted part of that person's life already. And then when they get sick, then they're going to trust you to take care of them, because you know, they know you, you're their friends. How about that?
Okay. No, thank you. Yeah, I mean, it really comes back to almost, you know, what you're asking for is revisiting 50 years ago, before the insurance machine took over.
Yeah, I mean, it's like the Norman Rockwell. Yeah. That picture of the little kid and the doctors. Yeah, it's exactly that. But doing it with technology.
I wanted to add, it's older than that. In very old traditional Chinese medicine, your doctor was paid until you got sick. And then when you got sick, you didn't pay it because, yeah.
No shit. That's a good idea, actually.
Right? Talk about incentive.
Okay. No doubt. Real. We are going to have to talk. You know, that's actually a really, really interesting idea.
It is. It's powerful.
That joins in with Bob's comment when I asked, what are your barriers? And he says, it's finance, you know. And so Bob, as a physician, you actually are aiming for health. You're probably the classic, since NASA, she's also the same for a veterinarian, Sarah as an NP role, to actually trying to be achieving this health. So you're saying that one of your drawbacks is finance. Talk a little bit more about that, Bob.
Yeah, it's definitely from a different perspective. When I was doing hospitalist work, that's where patients come into the ER. ER deems that they need to be inpatient. I take care of them from that moment on until they get discharged. So a lot of issues that we saw is literally finance, or access being one, but finance just rippling through the entire interview and processes. So they come in, obviously, years, if not months, of not caring for whatever it is that they have. Now they're having this emergency coming in 3 a.m. Friday for this issue. Turns out their A1C is, let's say, 15, 7 being normal or less than. And so we're taking care of them as an emergency, and then, you know, stabilize them. And then after that is basically, okay, these are the steps that you need. These are the medications. Oh, finance, I can't afford that. Follow up with your primary care physician, please. They're going to be the ones that's going to be following you. Oh, finance, I can't make it because I have my Monday through Friday. I can't afford to take one day off. Doctors aren't available on the weekend. So see you later. They are in their normal range after seeing me. A few months later, same person, same issue. And it's, again, not their fault per se. And it's like, oh, what happened? Oh, I couldn't see my doctor. Oh, my doctor retired. Oh, you know, my kids have this, that, and the other. And it's like, it's totally understandable. It goes back to the same, okay, well, let's try to, let me look at the medications. Let me see which one is on the $5 target plan. So in my mind, from a provider standpoint, I'm not just using my clinical skills of, hey, what's the best treatment that exists right now in 2021? It's what's the cheapest best that I can provide to this one patient that has these issues, non-medically related, but will be contributing to their health. So that's just from the inpatient standpoint. I'm working with long-term care folks now, and I see the same thing. They're fortunate enough to get Medicare/Medicaid, but when I don't see it, when they recover from their rehab, it's, hey, okay, make sure you see your orthopedic, make sure you see your PCP. We kind of stabilize these things, and to the most part, some of those issues come back again. work comes back, and finance. So that's a huge one. I mean, there's tons of other ones, but that's the huge one that I keep seeing back and forth over and over.
Yeah, no, so there's a couple things there that I see. Finance could be, hey, I don't have insurance, or I don't make enough, or like you said, I don't have time. It's inconvenient, right? So let's put the first one aside for a second, because I think that's the bigger issue, the more intractable one, right? But it's inconvenient. I got to go to work. I can't afford to take time off. I've got 3 kids and 2 jobs, and it's the only way I can make money or make ends meet. Doctors aren't open. Sorry. Well, is there any reason that doctors are only open? Why is it that doctors are only open Monday through Friday, and you got to go into the building to see them? Why is that? Well, because that's how they get paid, and they get paid. They have no incentive because they're selling encounters, and doctors, most doctors are way overbooked as it is. So it's not like they could make more money if they had more convenient hours. So where's the incentive? But if you had a situation where, hey, I'm going to get paid up until that person gets sick, right? Then I'd have all kinds of incentive to use all kinds of technology. And oh, by the way, there were no rules and regulations around where that care had to take place. Then you could use Cirrus MD. With Cirrus, you don't have to take time off from work. If you have a desk job, you can go to you can go to the doctor in the middle of a conference call. You just do it on your phone while you're doing it. I've done that. If you're in a factory, during your half-hour lunch break, you go to the doctor in the break room. If it's 3 o'clock in the morning, you go to the doctor, and you get your, you get in, you get out. You get to see the doctor in 45 seconds, for instance. And you see what I'm saying. Now apply, if we now turn loose everybody in this room and 1,000, for every one of us, another 1,000 people to come up with new and innovative ways to do that, we can get around that issue. We can make it convenient, delightful for anybody to receive care. And it'll be different because the person, who lives on the Navajo reservation, like, we've been trying to do business with them for a long time, have one set of constraints. The people that are on Medicaid living in, say, downtown Seattle have another set of constraints. The people that live in a nice suburb of Seattle have another set of constraints, et cetera, et cetera, et cetera. So it's not the same, but we can fix the access issue, I think.
Well, that's interesting because, sorry, go ahead, Margie, because I was just going to ask
sitting here
if
just
you
like
jump in.
Oh, I have so much to say.
Yeah.
So I have a senior living marketplace for senior communities and people looking for care. Our target market is that adult child or a professional, a doctor or a lawyer who are looking for care for their patients. But I also, my customer, the people who pay, are the providers of service. And what you're speaking of, it speaks to them as well. So the providers of service, when you talked about agency, I wrote it down 3 or 4 times. That's exactly what we're trying to do with Golden Sherpa, is give people agency, not just the people looking, the seniors and their children, but the providers too, because every time you get a client, it has to work for, there's a relationship there. And we are trying to make it a place where people want to come, because just like that little ache, nobody really wants to be thinking about their aging parent. And so everything that you're speaking to, we're doing it, but we do have problems because like you said, people don't want to think about it. And when you're of the beginning trying to give people that empowerment, I just had last week people calling me, 2 people themselves on Medicaid, so talk about money, who one had electric wheelchair, and to find a community that would actually support just her electric wheelchair. That's not an easy thing. Some of them they don't go in a ramp. I mean, how the space. So this person was trying to get out of a nursing home on her own. And she does have supports from her Medicaid. She has a social worker, but she was trying to get agency for herself to find community. And another gentleman who called me like the day before, he called me, I'm going to go to a homeless shelter if you can't find me a place today. They're discharging me from the hospital.
Yeah.
And my question, do you have a social worker? Because again, it's a Medicaid. Yes, I do, but they told me here, if I do it myself, I would get placement quicker. So again, seeing how powerful these people were. Not, one was in her 60s, early 60s, and the other gentleman, he was a little bit older. But they are trying with technology to have some agency, and we're trying to give that, but it's not an easy thing because we're trying to build something, telling providers, you need to see that you actually have choice. You can talk directly and you can do it using technology. That is one of the things providers asked us. They said, I want to do assessments. So we have in our technology, we actually can do virtual, live stream meetings like this with clients. And they asked us to put that there because they wanted to assess potential clients. We of course market it as virtual tours, but it was for providers. And again, giving people the empowerment to make decisions about their own business. But every piece of it, the first thing they want to know is what's the daily rate on the client? What type of additional health services can we provide? Because that's how they get paid. So payment is always a big conversation unless it's a private pay client, which is very expensive for most people.
Yeah, well,
so I love everything you're saying. I'm sitting here writing it down saying, yes, Margie, keep going. So many people are starting to have this conversation. And, the new term is that care economy. So that's what we work with. We work with people in that care economy. And I'm so glad people are starting to talk about it and take it seriously now. So
how are you defining that? That's an interesting concept.
Excuse me?
When you say the care economy, how do you define that as something new that,
Right. Well, it's just the term that they're using, but it is just all the people who are providing care for seniors and their families. So it's just a new term.
Okay, cool.
So as in a marketplace, or the economy as in we're going to try and deliver care in the most economic manner with the right level of resource set?
I believe the care economy, I was just part of a panel with the Secretary of Commerce, Deputy Secretary of Commerce, and that's really where it was introduced to me when they said, Margie, you want to be part of this care economy conference? Okay, sure. We care for our seniors, but it really is, there's economics within providing care. So who is providing that care? The caregivers, the care worker, maybe the child, and what does that look like? The provider of care. So it's really everybody who is serving for health of seniors, but not only seniors, also children. So part of the care economy, that same idea. And we all have agency over who takes care of our children. So it's the same idea, we always think we have choice there, or financially we have choice, but sometimes we don't think about that when we're talking about rare disease, right? Because we don't have information. We get so much information at the beginning end, right? When you're born or you're preparing, but you don't get a lot of information when we're towards the end of life. And so I think that's all they're talking about, it, bundling it together. But
So something inclusive of an entire ecosystem. It sounds like, Margie, is that okay? That's awesome.
I'm wondering, was the conversation largely fiscal, or were they talking about emotional burden?
Emotional burden, it's all part of it, right? Because it is one of the biggest things that we try to do, at least what we're trying to do with Golden Sherpa, is release that burden of not having no knowledge. When you're an adult child or you're a senior, you're in crisis, you need information pretty quick. And I'm sure Bob can speak to how fast does he have to get families up to speed when you're sick and you need to be discharged, or what does that look like, right? They're in the hospital for your patient. So knowledge.
And knowledge which is actually tailored for the receiver. I mean, that's a big piece of what, at least what we've been asked, what we hear requests for from doctors and care providers is specifically that. I could, to the earlier point of, you have a disease. Well, what does that really mean to me? And how can you frame that in a way to where the patient can consume it and actually make use of it?
Yeah.
And it always falls on the Bobs of the world to try and come up with that really quickly right before they have to jump to the next patient, which is not ideal. It's really not. It's quite difficult. So
I think, you know, Margie, the point you were making about the physicians having agency, and I think that's really important. I mean, how many times have we heard about physician burnout or physician, you know, dissatisfaction? I empathize for them, because it's not like physicians are out to game the system. No, they're trying to take care of people. That's what they, you know, that's what they, but they have to, you know, they still have to make a living. They still have to send their kids to college. They got to put food on the table, and increasingly they don't have the ability to really do things autonomously the way they want. They have to worry about, again, their overlords in the health plans.
So you were,
or they're, you know, if they're in a large health system, the administrations of the health system. So I think they probably have a sense of helplessness every bit as much as the patient does. I mean, right? Am I right, Bob?
Yeah, absolutely. I mean, absolutely. We've only touched upon patients, but I mean, the whole reason for the burnout, at least one aspect, is literally you're trying to provide the best care as you can, but suddenly instead of 15 patients a day, you're asked to do 25 patients a day. Forget about income, which is stagnant. But hey, get through those patients quickly. Oh, by the way, you know, we're going to start weekend clinics now too, and you're going to rotate through that with everybody else. That's not in my but you like it or you don't like it. That's what we're doing, and that's the case. Yeah. What can you do?
Right.
Yeah. Jack, you are funding multi-system innovation through your venture capital, and can you tell me some of the projects that you might actually be funding through your program that are trying to address some of these things? I realize there might be some confidentiality in who gets the funding projects, but maybe you could speak in generality about how you are definitely a system provider, and you're the VC part of the system provider. So you're wanting to make sure that the connections work to make your system more effectively. What are you funding?
Yeah, that's a great question. Any health system venture activity needs to have areas of focus, is a pretty key thing, and ours tend to be in areas that are going to make us successful in managing populations of patients. So as we move from fee for service to fee for health, I guess you could say, that's what we're sort of focused on. So it's pretty wide ranging. And I would say that, okay, I'll give you an example of a project that we're looking at. It is a company that is trying to move care processes from clinical personnel to caregivers of patients in congregate care settings. So it's a kit that is designed to be operated by lay persons, I guess non-medically trained persons. The kit is inclusive of sensors, a preloaded iPhone, and AI technology that allows it to walk the caregiver through certain monitoring processes that before would be performed in a clinic by like a nurse maybe. And so these are sort of routine vitals or depending, it's difficult because it really depends a lot on the patient, but it's a modular solution. So health systems like mine can identify the right sensors to plug in to the kit. That's what I mean by modular. And then it goes to the right patients. In a SNF, for example, their caregiver is the one who performs these readings, and it walks them through how to collect and report those readings, in which the reporting is done automatically. And It notifies the caregiver and patient when readings are outside of a predetermined thresholds, when to seek additional medical attention, et cetera, et cetera. And so what this does in the context of what we were talking about is it moves care from the facilities that we currently operate to the community setting, and it reduces the cost of care, it empowers caregivers, and things like that. So that's an example of a solution that we're looking at that is this sort of population health area.
And we could speak about that from a health system perspective. What we could also think about is that really just transferring the care out of a hospital onto the burden of some unpaid provider, for example, a family member, often a woman, to be moving the care to that. So Bob said moving care from clinicians to non-clinicians as a vested interest in the patient in between clinician visits, yet allowing data to be communicated to clinician. We've got lots of innovation in that area.
Yeah, there's a lot of value that I'm not adequately capturing. To my explanation, I apologize.
No, it sounds like a great project. I think it's really, and that's the exact kind of things that are coming forward to investors to be looking for them to fund.
I mean, I would look at that. Yeah, I agree. I think that is really the way. I'll look at it a third way, which is that let's look at it from the patient's point of view. Hey, I don't have to get out. I don't have to take time off from work and drive into a place where there's a lot of sick people. Like really sick people, and risk becoming infected, and I get to stay at home and get the same value. That's value. That to me, that's framing it that way is thinking about the customer first, where the customer is the patient who needs that monitoring. That sounds like a great experience. I would really, I would love to do that rather than having to go into a clinic every time I needed to be monitored.
And it brings back to the forefront preventive care, which is what medicine was truly made to be, rather than, ER visits. So.
Yeah, exactly. And it cuts down on the cost. I mean, to your point about preventative care, getting people care, lower intervention care sooner. I mean, that's what Cirrus, that was the initial impetus behind starting Cirrus. Now it's gone beyond that, but that was the idea, is that if you can get people access to a doctor right away, they'll take it, they'll use it, and that's a good thing. And you can blow that across the whole rest of the industry in a way.
Shiloh, you said that you weren't so experienced in health, but that's not quite true, because you as an individual are healthy. And are there questions that you might like to ask to the other individuals here about things that as a community person that you would like to see happen in your health system? And we can come back to Shiloh if he's not actually just here at the moment.
I was just going to say, all these technologies is fantastic. It truly, truly is. And one thing that we're facing with our startup with the kiosk is that it's great. Like everybody on this panel, X years below can use it, right? Because technology is ever present and they've lived in this world with technology. But one of the things that we're trying to figure out, in addition to maybe the company that Jack's thinking about, is what about folks who are above a certain age, where they're not used to or not able to use the technology, arthritis in their fingers, they can't really use it. And then one of the things that we're trying to figure out is, okay, can they use like an Alexa or a Siri where they can just verbalize, call my doctor, or I'm reporting my blood pressure is blah, 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 where it's literally a verbal communication to this technology. And there's that gray area where we won't reach everybody. Somebody is going to need their grandkids to activate one of the systems. But that's one of the things that we're looking into too, given all the technology that exists. Like there's a certain population that we're not going to be able to reach, and how do we reach them? How do we create a better bridge towards that for them.
On that note, you know, I was also thinking the technology is great and it's exciting, but it feels like we're having half a conversation, because there's also the conversation of who's going to do the work. And Elizabeth, I think your point about how the burden of care is disproportionately placed on the women of families. And we're going to find situations where, like in Asia, I can't remember what it's called, the triangle generations, there aren't enough kids to care for all the elders, right? So what are we doing in the healthcare system to increase the number of PAs and NPs? What is the certification, enough certification that we can entrust people in a community? Could it be a clergy member? Could it be the school nurse? Where else can we find points of, I don't know what the right word is, but certified care, some modicum of education that can be helpful, because health literacy is low, super low. So even if we equip them with the tools, it could still all just be gibberish, right? And one of the things that I'm focusing on right now, because I spent so much time like doing top-down healthcare transformation initiatives, really looking at the opportunity to do more of a ground up, working with coaches and working with, that's my business. So I created the Startup Workbook Factory, and I'm working with coaches, fitness, health, business, any kind of coach. But I see the opportunity for people who don't necessarily have MDs behind their name can still impact health. And tools like what you were talking about, Jack, could be useful in, somebody help me out with like the right term in terms of tiers of education. You know, could we use an LNP to do this work and increase access? What is happening in legal? What are the laws about practicing care across borders? I know COVID helped a lot with that, but those are going to sunset, right? So I think that's a whole nother part of the conversation that's important, is the actual people.
Well, when you talk about care, at least in the senior space, we have caregivers, and we're talking about the care economy. These are people who are generally, they have a certification to help, and they're the ones who are in the room. They're changing the bedpans, they're helping the seniors get up and, do transfers and stuff like that. So when you have technology, as Jack was just mentioning, that actually gives them the opportunity to serve. Right? They can use the technology right there at the bedside, and they're the ones, not the nurses, not the doctors, but they're the ones providing that care. And when we talk about, at least in seniors in the care economy, the ones that I'm meeting, honestly, are immigrants who are coming to our country, and they are building businesses, small businesses, and they're serving our population. And they do a wonderful job, and just like doctors, they have burnout too, right? And when we talk about, again, that care economy, how much do they get paid to provide service? And this period of time that we are in right now, it's been really great, because there's actually some light on how much does it cost, who's providing the service. And as we age, we know we're going to need more people in this area. And when we talk about in-home health, so long-term care, residential care, they are providing care in those. They're providing the in-home health. They're providing the in-home care. So these are people who, with technology, we can have them serving better. I think that's a great opportunity for our country, and, across the board internationally as well.
Do they have a formal certification that
well, there's like a CNA certification that they have, CNA. So yeah, some of the owners of these communities, nurses or doctors, yeah. And those are small. So we're talking about foster homes for seniors, adult family homes in Washington State, have them in all across the country. And then also, mid-size assisted living communities. Generally they have, COVID has really helped them, because they were able to get the doctors in during using like Cirrus MD, right? And they had people who were making house calls, and hopefully some of all that stays and can help these providers of service, because they are also, if you have an adult family home, for example, they were having to get that client to the doctor. But now everything came to them, which is just wonderful for all of that community. So hopefully these are things that we can embrace, and using technology to help them provide that care too. Like a script on that would be great.
Last week, Glenn mentioned that he gave an example several weeks ago about someone who had a care condition and the family member actually was not getting any payment to be able to provide assistance, and how laws were starting to change in small communities to allow people who are most familiar with the patient to be able to provide care. I think it requires a multifaceted approach. And at one point you talked legal, Chris, and Alicia asked, what are the changes in the legal systems? But it's sort of like government policy. It's one of these, if we think about multiple players in this, policymakers are key ones as well.
Yeah, I mean, that's so true. I mean, you've got, well, just at Cirrus, we would run into, we'd have to think about what Congress was doing, what the IRS was doing, believe it or not, what HHS and CMS were doing, which are administrative, they're not legal, they're, the regulations are different than laws. Then we have to look at what happens in each state, both in terms of the licensing, because we had doctors in every state, so we had to get licensed, those doctors licensed in every state. But then you have to worry about the boards of insurance, because they dictate what's possible and what's not possible for us, or because we dealt mostly with health plans, and in some cases there are local regulations you have to comply with. So it's massive, and it's just really, really inflexible. It's a major part of this issue. Figuring that out is a major component to all this.
I like Nesa's comments here about one factor that contributes to burnout at all levels of care delivery is a sense of futility. Do you want to jump in and speak about that?
Sure. So in vet medicine, there's actually some new research that came out that like our technicians, our nurses, if they work on a case, let's say they work in a 24-hour center, if they work on a case that goes on to pass away, let's say they weren't even in the building, just knowing that that patient didn't make it actually has a negative impact on them. They quantify things for providers as like satisfaction. So you can have professional satisfaction or compassion satisfaction is kind of the way to think of it. People who work in healthcare delivery, the CNAs that are changing a bedpan at an adults living facility, all the way through to your cardiothoracic surgeon, all of those people are motivated by an intrinsic sense of wanting to provide care, right? Care being defined as like compassionate attention or loving attention. So when you start boxing people up, the physician on here mentioned, like in the ER, when the person comes in, you know what to do. You might even say, go to your PCP and do this. When you as a provider know, you don't even have to follow up with the patient. You just know that it's not going to happen, or they don't have access, or I think he mentioned like that financial constraint. When you start boxing care down too much, what happens is you never get to see things through to fruition. So to go back to the analogy of playing a blackjack hand, how would you feel if your job was you were a dealer, but you had to get up and leave in the middle of each hand, right? You just never know the resolution of things. It's much more satisfying for us psychologically as humans to see things through to the end, or know that what you did made a difference, not just in this moment, but on the case overall. Does that make sense? Resolution of the healthcare need of someone is an important factor. Futility or stagnation is sometimes also the word that's used, is a concept that is applied in a lot of other spaces as well, in like human resource management, right? If you have somebody who has a lot of ability to contribute to your organization, doesn't matter if it's health or anything else, if you do not allow them to express that, it kind of fosters a sense of frustration. And in burnout specifically, as I think, Chris was talking about initially, how great would it be if people actually knew their physicians? Well, the care providers would prefer that as well, right? Partly because they get to see those things through. That's why it's beneficial to the care providers as well. And working in veterinary medicine specifically, we are segmenting down more and more, right? There are more and more specialists, more and more difficult cases are leaving the GP space, et cetera, which is great, but it also means that we're not experiencing as much professional or care satisfaction as we probably used to.
Yeah, it's almost, again, getting back to your point, Chris, regarding the consumerization of healthcare. Everyone becomes a cog within the machine, and you're inserted at the point of need. And then, yeah, you don't even know what's going on with the patient, whether or not, unless you're called back in because, oh my God, something went horribly awry. Some of what we've seen success with, specifically with DoD and VA, because they have the luxury to engage in this fashion sometimes, is the really the patient-centered home concept, which you've got a care team which has responsibility for 20 or 30 different patients, and that is your home as a patient. But unfortunately, I think to your point, the economy itself is not structured in a way to support that across the entire nation at this point. And getting that shift started is kind of the next step, if you will. And I don't know if a single payer solution, every Medicare for all, would actually provide sufficient flexibility for that to start to come forward. Because again, it is a bit of a return to the olden days, if you will. But I think it gets back to the concept that Alicia brought up. You're getting paid for someone actually getting better. And you have a relationship with that person. And you know what's going on with that person going forward. And you have some investment in that person getting better. Not just the fact that you're getting paid, but more importantly, you have that relationship. So, and it's sad to hear that that veterinary medicine is unfortunately going the way of human medicine. That's sad.
Well, to that point, I pay cash so that I can go see an ND who will talk to me for an hour and 15 minutes about all the things, right? And, in the state of Oregon, NDs can prescribe everything but marijuana, but I don't need that, so I'm good, right? Mm-hmm. And I have a really good relationship with my primary care physician, and I'm willing to pay extra for that. I'm fortunate that I can do that. But what you're talking about, can that relationship, and it kind of goes back to the first thing I said about people who engage the medical system because they're looking for some kind of human connection, right? We look to the healthcare juggernaut for some kind of nurturing, not just Band-Aids, yeah? Mm-hmm. I think about that a lot. About how we support each other as human beings with like pets and grandkids and stuff, and not just bones and skin and teeth. Yeah.
Well, yeah, and I think that really speaks to again what it is the product should be. And what does health? If we're gonna, that's I think where. This insight is so important because not everybody needs the same thing, especially in a country as diverse as the US. So I don't think that Medicare for all is the right way to go, because again, from personal experience, Medicare is about as flexible as an iron bar, as a bar or rebar, maybe even a steel beam. It's just not flexible. And whereas in a country like Norway or even Britain, where it's a lot more homogeneous, it's a lot smaller geographically, maybe you can get away with that. And even there's a lot of downsides of the inflexibility. But in the US, I mean, my God, what you need again on the Navajo reservation is not even vaguely close to what's going to be successful in downtown Denver over here, even though they're only, 300 or 400 miles apart. But they're 300 or 400 miles apart. If you go 300 miles in Denver or in Britain, you're probably up in Scotland by that time. Or maybe you're in Iceland, I don't know. But you get the point. It's just, we need, and putting the finance side aside, I mean, I think we've got the skills. I mean, it's not going to happen overnight. It probably won't happen in this decade, but we have the ability to give people what they want. And if what they want is they're lonely and they want a connection, and it happens to be your doctor, well, give it to them. Find a way to do it. Why should we not do that?
Yeah.
Why should we not do that?
And at the same token, when I was 120% travel, I didn't want that.
No.
I wanted to get out, right?
Yeah. You just wanted to chat with somebody on your cell phone.
Yeah, that's exactly right.
And those are both valid needs.
Mm-hmm.
Those are both valid needs. So give them, provide it for God's sake. Come on. And we can afford to do it if we get rid of all the waste that is created by the fact that we have to recreate a demand curve, a supply and demand curve, through the claims management system and all this bureaucracy that exists around how we pay for things now, which you wouldn't need, or you would need a lot less. In some cases you may need it, sure, but not as, you don't need it just to go to the doctor. I don't need to use the same mechanism, for my physical that I had yesterday as I did, I had cancer at one point. I'm really glad I had good insurance when I had that. And, that's a whole different, it's like home maintenance saying, well, it's changing my light bulb is about the same as changing my roof. Well, no, those are different things. Those are very different things, although they're both home maintenance.
Right. I want to be sensitive of our time. We've got about 10 or 15 minutes left. And one of the things that we did want to, Chris has actually been with Techstars, and he's had the opportunity to look at funding projects, and he has some views on fundraising. We're not really going to do justice to his topic on fundraising, but Chris has offered, if there's an opportunity that people are interested in, and having a one-on-one or having him come back to sort of talk about that. Chris, let you put out your thoughts on it.
Yeah, and I didn't want to interrupt the conversation because it would be a bit of a non sequitur to transition from this really interesting conversation to one that's probably pretty dry. I mean, it's not just the Techstars mentoring, but I ran an angel group, and then I've done 3 startups, and 2 of them I've raised capital, repeated rounds of capital. So I know a thing or two about this. And I just got some ideas, and I have this little set spiel that I give to companies that I mentor about this that need that help. So what I'll offer is, if anybody wants to, if that would be helpful to anybody, I'd be more than happy to talk to you about it. Give you the spiel. We can either do get the group together. I'll just throw a Zoom up, my own Zoom out. We can do it or whatever, or I can do it one-on-one. But yeah, it's about a half an hour spiel. It's not too long.
And if you're interested, you can just let me know, and I can coordinate that with Chris, and then we can tape it so that other people who are interested in it would be able to. So we've got Bob and Alicia shaking her head, and Margie shaking hers, and I think Ken would probably do so if he was just on screen. So Jack, is that helpful for you to hear his philosophy? Yeah, okay. His philosophy as well? All right, so why don't we, we'll either put it on, we can put it on another session like our Thursday education thing, or we can just do a half-hour spot on, and we'll just tape it and put it up on our webpage.
Perfect.
Great. Well, I think then, since we're not going to jump into that topic, if there's any things that you want to raise that we haven't sort of on this on anything, this is our dialogue. It's for us to learn something from, and so step in. Alicia, you're unmuted, so come on in.
Just because I have this, I'm really loving the metaphor of the blackjack table, and if I may be so bold to add, a component would be that you leave your money on the table. You don't get to see what happens, but sometime in the middle, they come in and tell you you can only play spades. Right?
Yeah.
Yeah. That's all. I just wanted to add that.
Yeah, so Nice has left, but we'll just tell her that we kept going with her analogy.
So I just put a couple of links in the chat. One is that podcast where Tony Miller, the CEO of Bind Insurance, talks about both how he thinks about pricing risk differently in healthcare. And, you know, everything I know about it, which is not very much, I learned from listening to that podcast. But it's really interesting. That's also the whole continuous function of health. Health is a continuous function, and trying to match up risk profile with time horizon is important. So that's the first one. The second one is this companion piece about economic, you know, 3 types of medicine that I put on the LinkedIn or the Meetup profile, which I think is interesting. And the third one, this one's really interesting. It's a interview with a woman who's a historian who has written a book, which I went out and bought. I haven't read yet, but about like how do we get this particular healthcare system? What's the history behind it? Why did it evolve this way? And I mean, whether it's true or not, I want to read the book, but you know, she talks a lot about how the AMA in the 30s sort of to preserve, ironically, just preserve doctors' independence at the risk of corporatization, pushed this system of health insurance. And so anyway, it's an hour long. I think it's really interesting because it sort of shows, and it shows that there were a lot of other models back in the 30s that were there that the AMA squashed that, you know, that sound a lot like value-based care or, you know, alternative payment models we're experimenting with now. And so it's not, I think that the lesson there is, hey, what we have now is not inevitable. It's not, and I'm just like, I like being a student of history. So I just thought I'd share that.
Well, it is important, as earlier someone said futility, but we've got hope. That's why we're all in this area, working on this, moving it forward. It's because we actually are optimistic and we have hope.
Yeah. Agreed.
Chris, given your experience with Cirrus MD, given, you know, in Seattle there's 98.6 or something like that, things are becoming text-based. What obstacles are you seeing, both, well, maybe from the patient standpoint, to using just text? Is there a period of time where it's like, you know, we're going back and forth with a text? It's like, doctor, you just need to see this, or I just need to talk to you, or something like that. Anything that came up through the development of Cirrus MD for something beyond text-based, or something that you guys developed?
Yeah, no, it's a great question. I'll tell you the history of it. So we started out, there is video. I mean, it's Cirrus is text, 98.6 is text, but we have video. We have talk on the phone with the doctor. But 95+% of all encounters, at least now, they're doing a lot of behavioral stuff now, and I don't know what that looks like, because that was sort of, again, I try to keep a bit of a Chinese wall there, but for the initial acute care model that we had, we initially had scheduled videos, we had chat, we were like, we're going to give people everything, right? What we found was that most people didn't want to bother scheduling a video. And half the time when they did schedule it, the doc on duty would come on, because ours is a staffed model. There's somebody on duty at any one given point. That's why we can have 45-second response times, is there's people there whose job it is, they're waiting for this. They're not in line at Starbucks like with Teladoc or anything like that. That's their job for that shift. And And so what would happen is the doctor would log on and see you'd have an appointment at 11 a.m. and you just say, well, let me just text the woman and say, hey, I'm here now. Do you want to talk now? And 95% of the time, it's like, okay, let's do that. Well, you know, okay, I won't wait till 11. I'll do it at 8. And after about 6 months of that, we just got rid of it. And now, because no one was using it. And so then we have it there now for the situations that you list, that, you know, the doctor is like, maybe thinks somebody's having a stroke, you know, like, yeah, you need video for that. So they can turn it on, or they want to get a look around the room, or, you know, there's, you know, now there's always image sharing. So you take just like you can text a picture, right? I mean, that gets used quite a lot. So let's like, hey, you want to see I want to show you my thing. Well, my wound or whatever. Well, people do that all the time, of course, but that doesn't have to be moving necessarily. A picture works just well. In fact, one of the things I used it for the most was strep throat between my wife and me. And let me tell you, taking a picture of the back of your throat, a still picture, is hard enough. Trying to do that on a video be absolutely impossible. I can tell you for a fact that no one could ever do that and have it, you know, have the doctor actually get any therapeutic use out of that. But Blake always would call these throat selfies. Like, yeah, that's a good way to put it. So at any rate, I mean, you really have to have somebody do it for you, and it's a pain in the ass. So point being that I think this was the thing I always got so frustrated about doing policy work down in DC is people are like, well, it's not really telemedicine, it's not a video. And I'm like, well, why is that? I mean, have you actually tried practicing this way? And, you know, like, the thing Blake always taught me was that the delivery of medical care, the actual delivery of care, is often about nothing but communication. Two people talking to each other. And text is a great way for two people to talk to each other, especially when a doctor's trying to execute a differential diagnostic process. Short question, short answer, short question, short answer, back and forth. Text is perfect for that.
Do you do
So that's the answer. Now, if you're trying to do a weekly therapy session, yeah, maybe there videos is the preferred way to go.
No, 75, don't quote me on the number, but 75% of diagnosis is all in the history taking. Then you do the objective, then you do these tests to confirm what you already suspected. Yeah. So, yeah.
You're taking your hypothesis.
And we typically use ER docs, and, you know, their job, you know, they don't always have the luxury of, you know, sitting there and, you know, navel gazing about things. They got to make a, you know, and those are the types of issues we brought in. And, you know, they were skilled enough to know, like, look, I can't diagnose this via text or video. Let's get you to somebody who can, and you know, make that handoff in an appropriate way to the appropriate setting.
Okay. Well, I think I'm going to draw us to a close, because we're going to lose a couple people anyways at the hour when other meetings are going on. So thank you for your time, your participation. Margie, great to hear your work and how successful you're doing, and the fact that you're connected with Glenn.
Oh, yeah.
Part of this is about networking. And we want you to make sure that you're taking advantage of the opportunity to network with others. Gwen has just introduced us to some community scientist work. And so we're going to follow up on that citizen science, a grassroots initiative. And so just keep on networking and using this as an opportunity to touch base. Thanks for your participation. We've enjoyed it.
Thank you.
Thanks, Chris.
Thanks, everybody.
Bye.
Bye.
Sure.